Good evening, everyone, and thank you for joining us for tonight's webinar. Tonight we're going to be addressing information exchange and care coordination objectives and meaningful use. And as always, I want to remind you that we do have the option for you to submit your questions as we go through this webinar. If you look to the right sidebar, you'll see a questions box. You can submit that, and ACR staff on the line will review your questions while we go through this. Also, we've got a very small audience tonight, so if you all want to save your questions to the end of our webinar, I'll actually open up the lines and we can have a nice dialogue about these measures or any other objectives related to meaningful use or health IT in your practice. We'll just open up for all questions at the end of the webinar tonight. Also, if you are experiencing any difficulties in either the visual or the audio tonight, please submit those comments in the comments box on the right toolbar of your screen. We'll monitor that chat box and make any adjustments as we go through tonight's webinar. Okay, so just to start off reviewing our initial slides here, a little bit about the Meaningful Use program. Just to remind you, this program is going to be implemented through 3 stages over the next few years. Stage 1, focusing really on just capturing that key health information that will later be exchanged and provide care coordination and quality measurement. Stage 2 will expand on that basic data capture to focus in on using the EHR for disease management, clinical decision support, medication management, and also to support patient access and care coordination through the healthcare system. Stage 3 is going to expand even further on those stage 1 and 2 objectives, and we'll really focus on how we can use the EHR to truly improve quality, safety, and efficiency in healthcare through decision support that's focusing on national priority conditions and self-management tools to really support the patient's role in their healthcare. Now in stage 1, which is the stage we're actually in and discussing right now, the stage beginning in 2011 and extending through 2012, with stage 2 starting in 2013. So stage 1 has 15 core measures. Now to successfully attest to meaningful use, you must meet the measures and objectives for all 15 of these core criteria. And then we also have a list of 10 menu measures, which you see on the right side of your screen. You'll actually need to meet 5 of those 10, and you can select any 5 for stage 1 to meet meaningful use. Now the meaningful use objectives are really set up to encourage you to collect that key healthcare data in structured form so that the data can then be used to support your practice through drug checks, drug allergy checks, and clinical decision support, and also using that core structured data to support patient engagement. And what we're going to be discussing tonight, using that data to really support care coordination and public health. And of course, underlying all of these objectives is privacy and security, and working to keep that electronic health data secure and patient privacy protected. So the first objective we're going to discuss tonight is the capability to exchange key clinical information, for example, problem list, medication list, allergies, and diagnostic test results, among providers of care and patient-authorized entities electronically. Now this is a core measure, meaning that it's one of those that you do have to meet in order to successfully attest to meaningful use and to receive that bonus payment. And the objective here is going to be measured by your ability to perform at least one test of the certified EHR's capacity to electronically exchange key information. And this test can include information on either a real patient, so an actual health information exchange instance, or you can use dummy data that simulates real patient data. Just something to show that your EHR has the capability to move that key health information. And again, you'll recognize that the problem list, medication list, allergies, and diagnostic test results all come from objectives that we discussed earlier in this webinar series. In order to meet meaningful use, you have to begin collecting this information in a structured form, and we're now moving to exchange that data. Now, this objective will be measured by a simple yes-no attestation. Again, no no metrics to meet as far as percentage points. You simply verify that yes, you did the test and you successfully did move that information. So what does this really mean? Well, for stage 1, again, all you have to do is send one test. Test your ability in coordination with your vendor to verify that your EHR does support the ability to move that information and that you know how to do that if you're able to. This does really depend a lot on future development of health information exchanges in order to do this efficiently, which is why they're only requiring that you test your EHR system one time to show that you can do this. Now keep in mind that in order to be a certified EHR system, your EHR does have the ability to do it. It's just ensuring that all of the cables are really plugged in and that you know basically which button to press and how to make it work. So the rule defines exchange of that clinical information as the movement of that healthcare data between different clinical entities with distinct certified EHR technology, and not between the organizations that share certified EHR. What does this mean? Well, this means that you can't use your EHR to basically send your patient's data to the provider down the hall that's on the same EHR system. Or if you are working under the same umbrella in the same EHR system as your hospital, you might not be able to send that data to that hospital to prove that health information exchange. So this means you'll need to find another provider in your community or get a vendor suggestion if they have an exchange set up and can explain to you how to move that data between those legal entities. And it really is two separate organizations. Now keep in mind that doesn't mean that it's necessarily going to be a different EHR vendor. You can have two instances of an Epic EHR that really are different EHR systems, even though they're both labeled Epic or eClinicalWorks or NextGen or fill in the blank with your EHR system. So what I would recommend is really talking to your vendor. They're the ones that are going to need to guide you through this objective and show you how to get connected and test that EHR to exchange the data. So the rule defines that clinical information as all the data that's needed to diagnose and treat disease such as blood tests, microbiology, urinalysis, etc. The key point here is that CMS really is leaving this up to you to define what that key clinical information is. So whatever it is that you think is important to move to that next provider of care. Again, very basic stuff, bare minimum of sending problem list, medications, medication allergies, and then whatever else you think is necessary. Now the rule also defines patient authorized entities. So who are you moving that information to? It's going to be any individual or organization to which that patient has granted access to their information. So if a patient comes in and wants their information moved to their primary caregiver, for example, you've got that patient's permission to send that health information. Now again, this is really focusing on who you're going to be moving the information to if indeed you are able to do this on a larger scale to actively support patient care. But for the purposes of meeting meaningful use, again, you only have to do one test, and you can use dummy data if you need to. So the next slide here, I've got some information on the certification criteria. I'm not going to go through all of this. The key point really is to show you that your electronic health record has been certified for meaningful use, and it can support the movement of basic health information. So technically, it's going to be able to do what it needs to. The key is, again, talk to your vendor. Find out how to make your EHR send information, and in many cases, they'll help walk you through running that actual test and set you up with an organization to test against. In many cases, they might have another organization on the same type of EHR system that they can help facilitate that information exchange for testing purposes. You can see here that in order to meet meaningful use certification criteria, they actually test the EHR system to see if it can exchange structured information on diseases, injuries, impairments, and other health problems and manifestations. structured lab results, and medications, and more than this. So what are your next steps? First thing you're going to need to do is talk to your EHR vendor. Again, verify that you really do have the ability to electronically exchange that information. This means more than just your EHR being able to do it and having a check mark next to that box, but actually making sure that you've got all the necessary cables hooked up and you're tied into the right systems and know how to configure your EHR to send that data. Again, you're going to need to know how to define what information it's sending. You don't necessarily want to just send an entire record, but if you can generate summaries of care or some sort of template, you might need to work with your vendor to establish that. So know how and what information to send from your EHR. Also understand how your EHR system can receive information. Where this objective really does focus on you sending that information and actively pursuing that, your EHR should be able to receive that information as well. Now this really helps in facilitating patient care if you have a patient that's coming from a primary caregiver across town and you want to receive their health information electronically from their EHR. So knowing how to receive that information and incorporate it into the patient record can also help streamline your workflow as well. Also, look at your internal policies in your practice to ensure that everyone on staff knows who is responsible for sending and authorizing this information to move and who's in charge of actually doing this and verifying that information makes it through and that everything is done according to HIPAA compliance and everything is documented correctly. So the key things to point out as we move forward to stage 2 and then even on to stage 3 beginning in 2015 is that we expect the networks and infrastructure to really grow to facilitate information exchange on a large scale. Right now we're talking about a test, just performing one single test to move health information using dummy data, and if you'd rather do that than using real patient data. But by stage 2, we really do expect that the policies and information flow is going to be established for health information exchanges on a large scale, and expect that these often expensive point-to-point connections really won't be as necessary. You should be able to hook into your regional or your state health information exchange and really start moving data through that organization. Again, one point and really streamlining the entire process. So for stage 2, these measures really are subject to change, but right now it looks as though recommendations will be for stage 2 connecting at least 3 external providers in your primary referral network or establishing an ongoing bidirectional connection to at least one health information exchange. Again, health information exchange organization being that regional or state organization that's established simply to facilitate health information data exchange. And by stage 3, we expect the measures to be closer to establishing connectivity to 30% of external providers in that primary referral network, or again, establishing ongoing bidirectional connection to at least one health information exchange. And I've got a note here at the bottom that, again, successful health information exchange really does require the use of infrastructure for that exchange, and it's a very active field right now. There was quite a bit of funding in the High-Tech Act to support the development of these organizations, and they really are ramping up quickly and in many states already moving health information. So our next objective to discuss tonight is for the EP who receives a patient from another setting of care or provider of care or believes that an encounter is relevant should perform medication reconciliation. So this is a menu measure, meaning that it's one of the 10 that you should select 5 from. And if you select to report on medication reconciliation, the measure here is to perform that reconciliation for more than 50% of relevant transitions of care in which the patient is transitioned into the care of the eligible provider. So this is really focusing on which patients are coming to you from an external source and then performing that medication reconciliation. So CMS defines medication reconciliation as the process of identifying the most accurate list of all medications that the patient is taking, including the name, dosage, frequency, and route, by comparing the medical record to an external list of medications obtained from a patient, hospital, or other provider. Now the key here is to really focus on those listings or documents that are coming into your practice to ensure that the medical record is up to date in your EHR system. So electronically looking at two lists and ensuring that the one in your EHR is the most up to date as possible. So a key here is relevant encounter. What does the rule define a relevant encounter as? Relevant encounter is defined as an encounter during which the eligible provider performs a medication reconciliation due to a new medication. So anytime you see your patient coming in and there's something new on that list, or they're bringing in a new bottle, or long gaps in time between patient encounters. So if a patient has been away for quite some time, you'll need to review that medication list with them again to ensure that it is up to date, or for any other reason that you think it would be appropriate to perform that medication reconciliation. So really an encounter is relevant if you determine it's relevant. And the key is that if it is indeed relevant, you're going to do that medication reconciliation every time. So this isn't just one time during the year, but every time you see that patient and feel that it's necessary to review and ensure that medication record is up to date. Now the rule defines the transition of care as the movement of the patient from one setting of care to another, and then clarifies that the receiving eligible provider would conduct that medication reconciliation. So this is key in that anytime you can determine your patient has been in the hospital or in another care provider's office, you really need to engage your patients to ensure that you know of any other transition that might have happened during that gap in care from the last time they were in your office, and then ensure that you are up to date on what happened during that hospital visit or office visit, and that your EHR is up to date and accurately reflects what happened during that other episode of care. So this slide really shows that, again, if you've got a certified EHR system, then your EHR should be capable of electronically comparing those two lists or more medication lists if you've got several transitions coming in from that patient all at once. You really need to work with your vendor to make sure you know how this functionality works. Again, part of the Meaningful Use program is meaningfully using that EHR system, which means knowing how your system functions and how to use it to streamline care in your practice and really perform these advanced functionalities that will provide safer and better care in your practice. Many times you might not know, or others on your staff might not know, how to really use this functionality to streamline the flow. So work with your vendor and bring your entire team up to par on using this. So again, the measure threshold here is for 50%. So 50% of those patients in your EHR system who come to you as some sort of transition of care or have experienced any kind of long gap in care during that reporting period must have medication reconciliation performed. So you also need to understand, how is your EHR calculating this? Work with your vendor to find out how that reporting module works. Again, your EHR is going to be certified so it's able to not only perform those medication reconciliations, but it's also going to be able to report on and calculate that measure. So knowing how your reporting function works will help you to really ensure that everything is documented appropriately and you're getting credit for meeting the measure in the work that you're doing. So next steps, again, verify that your EHR really can perform that electronic medication reconciliation and understand how it's going to report on that. Also work with your entire practice team to ensure that your clinical and operational policies and system configurations are up to par. you might need to enable a few extra features to ensure that everyone on your team who needs to be able to perform medication reconciliation is able to access that function. And we do expect that this measure will be increasing over the next 3 stages. Right now we're at 50% of all relevant encounters, and it's a menu measure. We do expect that this is going to move to a core measure in stage 2, and that the threshold will be increasing to around 80% of care transitions. And then by stage 3, we expect that it's going to remain right around 80%. So it's really going to help out your practice if you really start aiming for a higher threshold than that 50% now. Again, ensure all of your practice team is on board, and anyone who's able to perform medication reconciliation understands how that functionality works and understands when they're expected to do it. Keep in mind that although the reporting period is only 90 days in year 1 for you, after that, reporting period is going to be up to a year. So if you have any new staff coming on during the reporting period, you'll need to train them as soon as possible to ensure that everyone really is on plan for meeting meaningful use and understands their responsibilities and what the expectations are. So the next measure to review tonight is the eligible provider who transitions their patient to another care setting or refers their patient to another provider of care should provide a summary care record for each transition and referral. So the measure here is 50% of the transitions of care and referrals during the EHR reporting period have been issued a summary of care record. So for the last objective, medication reconciliation, we were really focusing in on patients that were coming to the practice and then acting on that. Now we're focusing on referrals and patients that are going away from the practice to other providers of care, and ensuring that the EHR really supports that transition by issuing a summary of care record to provide all of the records to the next provider on the care team. So the purpose of this objective, again, to ensure the summary of care record is provided to the receiving provider when the patient is transitioning for care. Now, it is preferable to send an electronic record if that other provider is capable of receiving that, but the measure says, or the objective states that the goal, again, is to ensure that summary of care record is made available. This means that you can actually issue a paper summary of care record to the patient, and that's still going to count for the measure. The goal is really to do whatever you can to ensure that record is making it to the next provider of care, and if paper is necessary, then you can meet the measure by issuing a paper copy. So again, transition of care here is defined as the movement of a patient from one setting of care to the next. So anytime your patient is going to any other provider in the care system, that can be another primary care provider or hospital, anytime you're aware of a transition, you're expected to issue that summary of care record. And your certified EHR should be able to generate that summary of care. You just need to work with your EHR vendor to understand how to establish that template to provide the summary, and then how to move that electronically or how to print that summary of care record. So again, the measure here, the threshold is set at 50% of those patients who are transitioning care, so moving away from your practice, during the reporting period must have that summary of care recorded. Now your EHR is going to be certified, meaning it's able to calculate this measure. So it's important to talk to your EHR vendor and understand how to document whenever a transition of care is happening, and how to document that you are providing that summary of care record. That's the only way to truly calculate the measure, and again, we want to be sure that you get credit for all of these summary of care records you're going to be providing, and that your measure numerator and denominator is accurate. And the only way to do that is to understand how the EHR is going to calculate that measure and what boxes you need to check in your system. So the next steps, you need to verify that you really do have the ability to perform medication, or this is actually incorrect. You need to ensure that you have the ability to perform a summary of care record for transitions of care. And again, that means that your EHR should be able to generate that summary of care record, but you might need to adjust that template. Chances are that it's just going to provide that basic information that's required, but coming from a specialty of rheumatology, you might want to put some rheumatologic specific measures or information in that record. So work with your vendor to ensure that the record really does provide the appropriate information for your patients going out to other providers of care in the system. Also understand how your EHR is documenting and recording those transitions of care and what you need to do to ensure that the measures are calculated appropriately. And also review this with your practice staff. Who is going to be responsible for generating that summary of care record? Who's going to be responsible for documenting this in the EHR system? All of your practice staff need to be on board and understand what their responsibilities and roles are, and to ensure that everyone has appropriate access in the system to perform those operations. So again, much like the last measures, we expect that the threshold here is going to be moving up. So right now we're set at providing a summary of care record for 50% of those relevant transitions of care, and we expect that to move to a core measure. And by stage 3, we expect that that's going to be 80% of relevant transitions of care and referrals. So our next measures are a bit different than the previous set. So I've actually included 2 measures in this next section. Both are the public health measures. Now you may be familiar with the menu set, and again you have to choose 5 of the 10 listed for menu, but at least one of those needs to be a public health measure. And if these don't apply, you actually can attest that they don't apply. So the first public health measure is capability to submit electronic health data to immunization registries or immunization information systems and actual submission according to applicable law and practice. And the second public health measure is capability to provide electronic syndromic surveillance data to public health agencies and actual transmission according to applicable law and practice. So the first measure, again, submitting data to those immunization registries. The measure here is that you've performed at least one test of the certified EHR's capacity to submit electronic data to the immunization registry, and then follow up with a submission if it's successful. Now there is an exclusion here, actually more than one exclusion. So first here you can attest that this doesn't apply to you if you administer no immunizations during the EHR reporting period, or if you're in an area where no immunization registry has the capacity to receive the information electronically. And you would simply do this in the meaningful use attestation system by checking a box that states exactly this, that you administered no immunizations or you were in an area with an immunization registry that does not have the capacity to receive the information. Now, what I've heard is that this will apply to many rheumatologists, as many don't necessarily administer immunizations, or they're in an area where the immunization registry, if there is one, isn't up for accepting that electronic health information quite yet. I can tell you that the public health information systems are really ramping up and trying to beef up their systems so that they'll be capable of accepting information like this in the future, but in most areas they're not there yet, so it's highly likely that you will be attesting to the exclusion here. Now, if you are in an area that has an immunization registry that can accept that information and you do perform those immunizations, all you'll need to do is work with your vendor in your local immunization registry to submit one test, data exchange, and one follow-up if it's successful. I also want to point out here that if you do test your system and you're successful in sending, but you get an error message or some sort of message saying that the immunization registry can't receive the information, that's still considered meeting the measure. A failed test is a test and will meet the measure for these purposes. And if you are not able to submit any immunization data to local immunization registries, you do have the option to select the second of our public health measures, which is to provide data to electronic syndromic surveillance data to public health agencies. And again, the measure here is performing at least one test, so testing your EHR system to send that data to the local public health agency if they're able to receive that data. And again here, if you're able to send any test data, then that's considered successful, even if it's a failed send and the local public health agency was unable to receive that. Now there are again exclusions here. If you don't collect any reportable syndromic information, then you can attest to that fact and be excluded from this measure. Again, working with your local public health agency to find out what information they're collecting, if any applies to you, and if they're even able to electronically receive that information at this point, and then move forward to either test that data exchange or to attest to the fact that you're not able to, or you don't collect any information to submit. Now, if you are unable to meet either one of these measures, that's okay. The rule says you need to pick one of the two public health measures, but you are able to attest that neither apply. And in many cases for rheumatology, this will be the way it goes. You'll just simply attest that you can't meet one of the or either of the two public health measures, and you can move on in your attestation for meaningful use. So again, what does the rule say about this? I believe we've covered most of this in our explanation, but simply you need to try to submit this information if, number one, you actually give immunizations and collect that data, or if you collect any data that's of interest to your local public health agency for syndromic surveillance. If you do collect either one of those, then you simply test your electronic submission if your local public health agency is able to receive that, or you simply attest that neither of these measures apply to you, or you're in an area with the public health agency that's unable to receive that information electronically. And again, this test can involve either actual patient data or dummy data if you simply want to test to see if if you can submit. You'll need to work with your vendors to ensure that you understand how to actually provide this information and send it to the local public health agencies. And you might need to work with your public health agency to really ensure their system is set up to receive that information. And again, we've got the certification criteria listed here just to show you that, yes, if you have a certified EHR, technically your system is definitely able to issue that electronic message and able to send it. It's really a matter of whether or not the public health agency is able to receive it on the other end. And if you are conducting these tests and ready to attest that your system can send data to your local public health agency, you'll need to maintain evidence of that. So any screenshots during the test showing that you did send a message, or even screenshots showing a failed message, will support your attestation. And in any case of future audits, pulling that information will definitely help support the fact that you are a meaningful user. Okay, so that was a very quick review of the Health Information Data Exchange and Care Coordination objectives. So at this time, I'll open up for questions. If you do have a question, you can either use our questions chat box, or I'll be happy to open up the lines, and you can use the raise your hand function on that right toolbar. You simply raise your hand, and then I'll open up the line, and you can ask your question. Okay, so our first question for tonight: will workman's comp visits be excluded when calculating encounters for meaningful use criteria in general? This is a great question. So the answer to the question is no, there really aren't any excluded visits for calculating meaningful use. The meaningful use measures take into account all patient visits that have occurred during that reporting period, regardless of the insurer or the patient diagnosis, really any patient that's come to see you. Now, our measures do break down according to certain objectives. So some measures will only look at unique patients, which mean only those patients who have come to see you more than once during the reporting period. And some measures will only look at those that are recorded in the EHR, whereas some will look at those encounters that are stored in the EHR, but also require you to document any encounters that are still on paper records and to calculate your own measure. But the key here is that a patient visit is a patient visit regardless of what insurer or what diagnosis they have. Okay, do we have any other questions tonight on any of these measures or any other questions on meaningful use or HIT in general for your practice? Okay, well, I believe that's the end of our webinar for tonight. I will leave the lines open and unmuted for the next 5 minutes or so. So if you have any specific questions to your practice and want to discuss that further, I'll be happy to stay on the line and answer any of those questions.